It takes teamwork to treat a patient, and the University of Pretoria School of Healthcare Sciences provides the knowledge and skills that enable you to be part of the treatment and care process, even for a potentially life-altering condition. Nurses take care of patients from the moment they're admitted, as in the case of an incomplete spinal cord injury, where special care is required. From positioning the patient for X-ray imaging to reduce the risk of complications due to immobility, this daily regime continues all the way through to rehabilitation. The radiographer uses ionizing radiation for imaging of internal structures as a key diagnostic tool in different medical disciplines. They may also provide support during surgery. The images produced assist in proper diagnosis and the treatment plan required. Dietetics focuses on preventative, promotive, curative, and rehabilitative aspects of human nutrition. In hospitals, dietitians design a specific diet to facilitate the process of treatment and recovery. The patient's nutritional status is assessed, monitored, and optimized through special feeds. Physiotherapy focuses on physical rehabilitation to optimize the functional ability of the patient by means of joint mobilization and improving muscle strength and functioning. The rehabilitation program enables the patient to move independently. In this case, through strength conditioning, patients gain mobilization from their wheelchairs and ultimately are able to walk again. Occupational therapy aims to assist people with loss of function due to disability to optimize independent and optimal functioning in occupations across their lifespan. Occupational therapists enable individuals to perform activities of daily living and provide adaptations, assistive technologies, and home modifications. If you have a passion for healthcare and want to change lives, the School of Healthcare Sciences in UP's Faculty of Health Sciences can prepare you in your journey. Our academic programs are embedded in research that matters. Become a life changer and put your commitment into practice.
Dimasiari, good afternoon to our viewers. My name is Fumulani Mavis Mulauzi. I am the South African Research Chair of Ubuntu Model in Nursing. Today, we are going to discuss a very important topic, and the topic is about the use of indigenous medicine in healthcare. I've got a panel of experts that will be sharing their information with you. For many centuries, indigenous medicine has been marginalized. The healthcare professionals are being taught about the way of healing, but which is only from the Western side of knowing. The indigenous ways of knowing have not been mainstreamed into our current curriculums. And I think this discussion today is going to address those issues. For as Africans, we have got our own indigenous vegetables, we have got our own indigenous herbs, and also our own African way of healing. So today we are going to talk about these issues based on the fact that the World Health Organization has already indicated that traditional medicine must be mainstreamed in the health care stream, but a lot has happened. In South Africa, for example, we have a Traditional Health Practitioner Act of 2007, but still we have not seen any changes going on. And I think the issue of COVID-19 has brought a lot of opportunities for us based on the fact that in Madagascar, Artemesia Afra was discovered as one of the herbs that can be used in treating COVID-19. And that on itself made people realize the importance of using their own herbs. So with me here today, I have experts, and the panelists are going to share with us, and I have for the deans of health sciences. I have Prof. Nemtandani, who is the Dean of Oral Health, of Dental Health at Wits University, and he's also the chairperson of the dental health schools in Africa. So based on that, he's gonna share with us a lot regarding decolonization of the mind. I also have with me Dr. Mabena, who will also be sharing with us about African traditional healing. Dr. Mabena is a traditional health practitioner who is currently practicing at Mamelodi. I also have the Deputy Dean Teaching and Learning from the University of Pretoria, Prof. Vanessa Steenkamp, who's gonna be talking to us about the medicinal value in our indigenous vegetables that we're eating every day. And then we also have Dr. Mahoro David, who is also going to share with us the indigenous herbs that we have in our country and how we can use them in healing. And lastly, we have Mr. Mueta Mabicha, who is from the University of Pretoria. He is an expert in the issue of curriculum. He's currently doing his studies, his PhD study on how we can mainstream indigenous health in the curriculum of health professionals. So I will just give my panelists a few seconds to just introduce themselves before we continue. I'll start with you, Mr. Mabicha Meta.
Thank you, Prof. As indicated, my name is Mabita and I'm a lecturer at the University of Pretoria. I am actually facilitating teaching and learning for postgraduate students who are doing their nursing education. So I'm basically teaching people who want to be teachers of nurses. Thank you, Prof.
Thank you.
Thank you, Prof. Mlautse, for affording me the opportunity to come and be your guest. I'm Madimeja Magoro from Tombe Seleka College of Agriculture, Senior Lecturer, Head of Department, Agricultural Extension, Economics and Partnership.
Thank you, Dr. Mahoro.
I'm Professor Vanessa Steenkamp. Thank you, Professor Mulaitsi, for the invitation this afternoon to speak to our audience and being part of the specialist panelist committee. I am currently the Deputy Dean of Teaching and Learning from the Faculty of Health Sciences of the University of Pretoria. My research focus falls under the Department of Pharmacology, where I'm involved with drug development and toxicology studies on traditional herbal remedies. Thank you very much.
Thank you.
Thank you, Prof, for the time given by your institution. Thanks. My name is Ephraim Gamabena. I'm a traditional healer from Mamelodi. I belong to an organization called Mutung. Mutung is a smaller Nyana conclave that is trying to promote the indigenous knowledge system. Thank you.
Thank you very much.
Thank you, Prof. Mlaudzi. I'm Prof. Nemotandani from Wits University. I'm the Dean of Dental Schools in Africa, who has been working with indigenous health practitioners all over Africa. Thank you.
Thank you very much. I think you have seen that we have experts in this studio this afternoon. So I'm just not going to waste time. I will make sure that they start presenting. I'll start by Prof. Nemtandani. Prof. Nemtandani, you know, we have been colonized for a very long time. And I think our mindsets really need someone that could teach us the way, a better way of decolonizing ourselves, of looking at things totally different. And I know that you have been doing this kind of work for a very long time. We'll really appreciate it if you can just, you know, in a few minutes, just brief us on how can we, as Africans and also as health professionals, start looking at indigenous medicine in a different way, and how can we also look at how to mainstream it into our current curriculum?
I think one should start from just giving a little bit of the background. As you listen in the media and in many of the universities, we are talking about decolonization. But actually, we need to go back and say, what has happened before we talk about decolonization? There has been colonization, and this colonization has been a well-planned project. It didn't come by mistake. It was not a mistake. It's a planned project with desired outcome. And that desired outcome is that we should stop thinking about ourselves. Stop thinking about Africans, practices, African way of doing things. The concept of Ubuntu, which the world is trying to embrace, we ourselves, we are not embracing it. So we should start by discussing the issue of what has happened to colonization. Now, this colonization had leaders who were tasked to make sure that they will make sure that we'll stop thinking about ourselves. Now, let's talk about in a simple context. What has happened? We hate about ourselves. We hate our shadows. Sitting next to Dr. Mabena could be a problem to most of the people. But what should be at the end of it? The universities in Africa are awarding degrees. These degrees, they are just about remembering what colonization has been all about. We are not thinking. Most of the knowledge that we are generating in Africa, it's put somewhere in the archives. We are not implementing it. As we'll be discussing it here, there are many people that have done wonderful research. But has it been applied? No. This is a challenge to all of us and universities in Africa. Thank you.
Thank you very much. I thank you for reminding us that we are colonized and we have to look at how are we going to colonize, to be decolonized. Indeed, you have given an example of a traditional health practitioner. When we look at traditional health practitioners, we really don't want to accept them, more especially in our allopathic or our mainstream healthcare system in the country. We really feel that they are bringing into something that is barbaric, something that is really not acceptable according to our ways of knowing. The type of knowledge that they are bringing in is something that we don't even know how to teach. So I really think it is very important that today, amongst our panelists, we have a traditional health practitioner, Dr. Mabena, and we are currently using Dr. Mabena as one of our lecturers at the University of Pretoria. He comes once a year to teach our own nursing students about traditional healing. So we have been working with him for a very long time. And today we would like him to share what is African traditional healing. Thank you, Dr. Mabena. I think you can now continue.
Thank you, Prof. Thanks for the opportunity, Prof. I'm not going to be long with my presentation. I just want to highlight quite a number of few things. But the topic will be the role of traditional healers and traditional medicine in the Western care system. I think, Prof, quite a number of people don't understand. It's either they ignore, it's not an issue not understanding, but sometimes it's an issue of ignorance. But at the same time, Prof, I must say that this is a very good system. There are systems within traditional medicine. There is a system of knowledge within the system itself. There is a survival technique within the system itself. There is a traditional healing practice system. The practice itself, it tells a lot. It needs not to be actually explained. And within the system of traditional medicine, we've got the diagnosing techniques. Within that, we've got theories of concept and causation of diseases. Prof, I must say that you know, the traditional healers themselves, they have scars. It's actually disappointing that 23 years we're in the government, that the traditional healing has no space at all in the industry itself. It's pathetic. It's disappointing. But based again, there are quite a number of people. There are causes that actually has landed up that today this practice is not taken very serious. It's because of the myth and the stories that are told about traditional medicine. It is because of the belief system, that the distortion that was called, that it's all about, actually it's all about witchcraft. And there are quite a number of people that who don't understand exactly what traditional healing is all about. The issue of the naming of the disease. The issue of the naming of the disease is it differs again, the way the Western medicine names the diseases. There is a lot that needs to be taught about the system, the way traditional healers are doing things. It differs with the Western medicine. Therefore, the more we are not, as traditional healers, we are not given an opportunity to explain about the way we are doing things, the way we are naming the diseases, that is actually going to be very, very difficult to understand. As you can see on the screen that you see the leg, it's got some ulcers there. How do we name that type of, that disease? It's a question the Western medicine practitioner might not understand. When I say that ulcer that you see, that leg that is having an ulcer, we call it chifola. And definitely the naming will differ, and that makes us actually not agree about quite a number of the causes of this particular disease. You can see the swollen what you call the face of that little boy, his face is swollen. Now we call it libanda, but in the Western science, it's called in a different way. So there is a lot, each one is very, very important among these what you call, these different practices. And again, the preparations of our medicine differ from, the Western part of it. The way you can see how we grind our medicine and refine our medicine, it completely differ. And that shows, again, how do traditional healers arrive into saying this medicine is poisonous, this medicine, it's not poisonous. It's time that each one teach one, the platform must be created so that, we must understand each other. The causes of, it is not always that the causes of illness in Africa, indigenous tradition, it's all about, witchcraft. No, we know exactly what are the causes of, of the diseases. We know exactly that what causes the diseases. The environment, the unhealthy environment can cause the ailments or the diseases. The eating habits, again. I might not go through those slides, but I just want to quickly move and show the importance of, we know as indigenous practitioners what are the causes of different diseases. The eating habits, to make sure. The unhealthy or the dirty blood, we always say, madi adi chila. And if you visit a traditional healer, explain about the dirty blood, we'll explain heavily, just to show that we know that how do we talk our language in terms of explaining the causes. The witchcraft, we shouldn't be shy that there is witchcraft. There is witchcraft that causes, quite a number of unhealthiness and in people's, well-being. Ancestral behavior. Ancestral behavior can cause, a certain punishment of some sort to a person to get ill. We shouldn't be afraid to tell these things. They are there. And disobeying the taboos. Those are some of the things that disobeying the taboos. that makes sure that the moral structure of the universe remains disturbed for good. And the interesting part about these taboos, when one violates one of them, secretly the person, when you violate the taboos, secretly the person may not go scot-free. The consequences will always manifest on the person concerned or the entire communities. These are some of the problems that causes the diseases. How illness are diagnosed in African way? There are many ways of diagnosis. People must understand that traditional healers differ from each other. And the traditional healing, the way of diagnosing in the traditional healing differ from the Western part of it. But that I must indicate that if we're not giving a platform, traditional healers are not giving the platform, to say these things, that will cause a damage. That will actually cause the way people are talking about traditional healing. The harm and challenge caused by distorted information about traditional healing. There is a great distortion that has caused that traditional healing mustn't be taken seriously. What are the results? Today we are faced with doctors and nurses who don't share with patients about the benefit of traditional religion. They can rather talk about the faith healing, not harmful of faith healing. What are again the results? The mixing of traditional medicine and the Western medicine, discouraged by doctors and nurses, it ends up fueling tension and mistrust between the two practices. And these are some of the results today. And then lastly, the lack of acknowledgement of signals from traditional health practitioners. That's another damage that has been caused by the distortion about traditional medicine. That again has resulted into one-way referral. I want to talk about the traditional and indigenous perspective of concept and health, sickness, and healing relationship with God. That's another distortion. That's another distortion that traditional healers don't believe in God. And I won't go into details about that, but that is resulted on what I've said previously, that the nurses and doctors can talk about, the good part of spiritual healing, not even the bad part of it, and the results. That emanates from that traditional healing don't believe in God, and it is not true. Again, I've gone through the way the preparation of the way our medicine are prepared. I just want to say something about what is happening during the treatment between the patient and the client. That is why traditional healers will take time when they talk to the patient. Why? It's because of before and during the treatment, traditional healers will frequently throw their divining board to learn if he's on the right track with the treatment. Once the spiritual cause of the illness has been established, the next stage in the treatment of the patient is the prescription of medicine, and medicine are commonly given in the form of powders and decoction. Those are some of, people don't understand how we work. People don't understand how traditional healers work. The compatibility, let's talk about the compatibility of African traditional medicine system within the Western healthcare. The two systems of healthcare have a lot of incompatibility areas. One, they do not have the same requirement of entry into their respective profession. Their code of conduct and code of ethics are not always the same. That it needs to be very clear, and they will never be the same. There might be some similarities, but it must be very clear that to those who don't understand the traditional medicine, practices. Their theories for causation of diseases are not always the same. That it needs to be clear. The condition of environment in which their practitioners provide healthcare are different. That is why we name the environment or the place we are working under, we call it Indumba. It's not a surgery, and a surgery cannot be Indumba. These are some of the things that understanding the terminology that traditional healers, as I've said, the causation of diseases, terminology that are used by traditional healers, it goes and differ from one traditional healer to another. And the only area that I would like to say that is very, very important is the only area of compatibility between the two systems in providing health care to patient, to read him or her diseases and to improve the quality of life. That is our concern. To better life, the patient's life. That is the most important thing. There is no competition. This is a traditional system that have its own way of doing things. It's not competing with others. It's actually today we are faced with a scourge, we are faced with diseases, a lot of diseases. It is time now we definitely need, these two systems need each other. When there was this discussion about the current plant that they called Artemesia Afra, that the very same plant is called umuti. But now because of, it's in Madagascar, they're talking about it. Everybody wants to grab that umuti. But it was not called umuti by other people, it was called herb. Those terminology, the way we are naming our medicine, it differs from one particular. The distortion about naming our medicine. All the medicine, including Artemesia Afra, for those who were talking rubbish about our practice, when we were using Artemesia Afra, it was umuti, and that the belief that Artemesia Afra is for witchcraft. But now, because Madagascar has come up very close and said about the Artemesia, everybody wants to grab that umuti. Finally, I want to say, the other area in which the two systems can be compatible is in the source of medicine processing, dosage, packaging, marketing, patient referral system, and patient history. Those are some of the common what you call. Who said we don't write the history of our patient? Who demonized the way we do things? I think the platform is needed that people must come and learn from us. Each one, teach one. Things to remember finally. Traditional healers has three important principles of treatment prevention. Finding the cause, curing the disease. That's the most important thing. These principles are the same as those followed by medical practitioners, Western medical practitioners, who looks for an objective cause, such as bacteria, virus, or growth, which is responsible for the disease in the body. I must say that currently, finally, I must say that there is regulation for the registration of traditional healers. I must mention that, even if it is very, very slowly, that is actually going to help to work under specific one roof. But people don't understand that why should be the regulation. Surely we want to show exactly that we do have code of ethics and conduct. And the government is consulting currently with the THPs and just to create an interim health practitioner and to provide regulatory framework to ensure that the efficacy and safety and quality of traditional healthcare services. Provide for the management and control over registration and training, because these nowadays traditional health practitioners is faced by the scourge of being sabotaged by bogus traditional healers. And definitely working hand in glove with the traditional healers and the government, that can solve the problem, because that will actually help us to make sure that we control, and the proper, well-calculated, professional traditional healers cannot be actually mystified or mixed with the bogus traditional healers. And so that for those who have been behaving and talking rubbish about traditional healers must now begin to talk. And this, I must quickly say that this is a practice. And this is a practice that is having Ubuntu within. It's a practice that surely when you look at your patient, you look at your patient through the glass, through the needle of, primary health care. It's not just a practice that, it's just maybe a practice that is the boom boom as other people are talking. It's a practice that is governed by Ubuntu. When you look at your patient, and be able to give an advice for the second opinion. I thank you.
Thank you, Dr. Mabena. It was really insightful, and I think we have learned a lot out from the presentation. I think the most emphasis was the issue of pluralism. You are emphasizing that we have to work, to have a space for both indigenous medicine and also for allopathic medicine, to enable our patients to make their own choices. Indeed, this was really very insightful. You have taught us about the different ways of diagnosing. You have taught us about the way you prepare your medications. And indeed, the most important part that I really liked was when you taught us about the way traditional medicine has been demonized, the way we look down to the traditional way of healing. So indeed, we really have learned a lot, and I hope our viewers, wherever you are, you can start asking questions. I really think you can type them and send them, and you can also tweet using hashtag UP-Ubuntu. And with that, I just want to introduce our next speaker, who is going to be speaking from the Swaziland, or the Kingdom of Eswatini, and that is Professor Priscilla Dlamini, who is the Dean of Nursing in Swaziland, and she's also the Director of Traditional Health Practitioners in Eswatini, and Priscilla is also a traditional health practitioner and a qualified nurse. Over to you, Priscilla.
Good day, ladies and gentlemen. This is Priscilla Sibongile Dlamini, the current Dean of the Faculty of Health Sciences at the University of Eswatini. I'm sorry not to be able to join the presentation live as we have planned, but I'm also aligning to the topic whereby we are looking at the indigenous knowledge system, especially in institutes of higher learning, and especially for nursing, and as well as also other health professionals. Indigenous knowledge system, as we know, it is really for indigenous, and it's long, way before even the Western or colonization began in Africa. We had our own healing treatments, rituals, customs, that made us to be what we are even today. But it has been looked down upon. When the Western took over, we changed all systems to be Western, including healthcare delivery. Even now, in some of our countries, we have just one system, which is the conventional healthcare system that is taking place, and that is popular. And our education, I will talk of nursing, but I've also observed with the medical profession and so on. we are not well versed with indigenous knowledge healing systems, and especially in Africa, and especially right here at home in Eswatini, where people think we are so cultural. We do a lot of rituals and so on. But when it comes to indigenous knowledge systems, traditional health practice and so on, you find that people tend to shun it and look down upon it. And religion has not also helped, because there's a lot of associating traditional healing with demons and so on, and it becomes worse when religion does that. Whereas our religion that we align with nowadays is very, very much new. Indigenous people, long time ago, had their own religion. Everybody do believe in God, and it doesn't mean if you're a traditional health practitioner, you don't believe in God. It is just for healing. It has got nothing to do with the religion and so on. We don't pray to ancestors. So this is just the background or the introduction that I'm putting forward. But in terms of nurses and so on, which I really, really emphasize, for me, I would encourage collaboration. And not only just collaboration for the healthcare delivery, but collaboration even in institutes of higher learning, where nursing education is taking place. And maybe also in addition, also for the medical profession, so that in all our countries we can have a dual system of healthcare delivery that is collaborating and assisting one another. I will take for an example of an illness that I once came across of a 12-year-old boy who had auto burns from head to toe, and nurses were overwhelmed and so on. And that boy was treated by an old traditional healer who claimed that illness used to occur in 1934. Luckily, he was already alive. Unfortunately, at that time, I was not able to follow up what exactly he did, but I went to have an interview with that old traditional healer. We failed in the hospital. The burns were not painful, but the poor boy didn't have any skin. He was burnt from head to toe. And these were auto burns. It's not like he was burnt by water and everything. And one was worried even about infection and so on. But this traditional healer, when he saw the newspaper, he went and requested Ministry of Health to go and attend to the boy. I was shocked to find that the boy has healed with no scar, nothing. The skin was back because of using our indigenous plants. Coming to even hemorrhoids, we are failing in the Western to manage hemorrhoids. Even the pain for herpes zoster, we are failing to deal with that pain. And being also a practicing traditional health practitioner, I know if a plant is even a simple one that can deal with that pain and it will be gone in 1 minute. So we've seen a lot. As midwives, we've seen that there are plants that enhance labor, but if we do not collaborate, those plants can be administered at the wrong time because they wouldn't know when to administer them. But if we're collaborating, then we will know that as a nurse, once you have progressed and the baby, the cervix has effaced well, then you will know that then you can request for that, concoction to be taken by the lady. So at the moment, you find that we are faced with a lot of problems, even just in our service area where we deliver things, because these traditional medicines are also drugs. It doesn't mean because we call them herbs that they are not drugs. They have their own active principle that can then act and interact with our own Western also medicines and so on. Either it can enhance or it can de-enhance, whereby they compete for similar pathways and so on. So I'm really emphasizing that collaboration has to take place. But not only collaboration, everything has to be internalized. Education has to be internalized. It has to start in our institutes of higher learning, whereby from the beginning, from year one, we do the integration of indigenous knowledge system in our curricula. We even have either courses or we even put up just a program on indigenous knowledge system, because it's a whole field of wealth of information and of scientific information that can be harnessed in indigenous knowledge system. We even have laws that govern IKS. We also have science in IKS. We have also technology in IKS that we need to apply. Then we can really strengthen what is our own, and not, of course, getting rid of the Western, but collaborating and so on. Unfortunately, at the moment, we find that the Western principles, the Western scientific pathways are busy being applied in the use of traditional medicines. Traditional medicines, you start with the clinical trial, you start with the person getting well, then you know that this works. Whereas when you do drug discovery, you do it the other way. Why don't we then adopt our own indigenous knowledge system in terms of even developing, our herbs, traditional medicines, and so on, instead of following the Western way, which can take up to about 20 years. For an example, the Artemesia Afra, in the West, they call it Anwa, and so on, has been discovered to work. But because we are thinking of the scientific way of doing things, then we think now we need scientific evidence, and so on. We don't need that. We need people who come up and say, yes, I have been treated, and so on. And then we can even observe them for side effects and the like. And as long as they don't report any side effects, then it means that traditional medicine is relatively safe, and so on. Then those who are interested, the scientists who are interested, then they can go to the laboratory and prove it and work on it, but do not stop it because it is helping people. Sometimes we even contradict ourselves, because in research we say if we find any drug that is assisting people and so on, even if you are doing your clinical trials, then you have to give it to the whole population. That's what happened with the D4T for HIV and AIDS, which was introduced prematurely, and it ended up causing a lot of side effects, but it also saved lives and so on. So this is what I would like to advocate for, so that we are all really being triggered and so on in terms of utilization of IKS in the practical area in our institutions, and also strengthening with the nursing and also the medical profession, so that we all work together. Normally in collaboration, we also talk of exchange of information. Let those indigenous people also learn something about what is happening in the Western healthcare, so that they are more knowledgeable and so on. For instance, I'll give an example of when I was developing the manual of traditional healers working with the HIV and AIDS and so on. We discovered that those traditional healers has to always inquire about the patient if they are already on antiretroviral, so that they should not give any herbal remedy, because in UKZN it was discovered that the African potato was taking similar pathways together with the antiretroviral, and it was rendering both to be inactive and so on. So based on that study that was done, so we advised all traditional healers that they can do the rituals, they can do any other thing, but once the person is on an antiretroviral, then you should not give your herbal remedies, because your herbal remedies are also treatment. It may either enhance or de-enhance the activity of both and so on. And traditional healers were listening and so on, and they did that, though not all of them and so on, but those who participated in the study, it was the buzzword and so on. So which means both sides have to exchange information. We have to learn from the traditional health practitioners, and they also have to learn from us. Coming to Swatini, status and so on of the indigenous knowledge system and so on, much as we don't have a legal instrument that recognizes traditional health practitioners in Eswatini, but they are recognized in the sense that nobody troubles them and so on. They are not going to court for practicing their traditional health, rituals and so on. The University of Eswatini even put up the Center for Research on Traditional Medicine and Indigenous Knowledge Plans. We have also aligned in the country ourselves in terms of those policies or those innovations in terms of the Nagoya Protocol, which deal with benefit sharing. We also have the wing of the intellectual property in the Ministry of Trade and Commerce, which has to also deal with the traditional or indigenous knowledge and so on. And with the advent, which is a recently put up Ministry of Information, Communication and Technology, they are doing a lot even in terms of traditional knowledge systems, and they do engage the traditional health practitioners. Unfortunately, we do not have a council of traditional health practitioners in our country, and this is what we are working on, because much as they are recognized and so on, you find that in a lot of ways the Witchcraft Act of 1905 is still applicable whenever it comes to a traditional health practitioner. If they are found with a skin of a baboon, then they would be locked in or they have to pay fines and so on. Whereas the way I look at it, if we can have a legal body in our country that govern traditional health practice and so on, then they can be allowed and regulate and standardize that maybe you can have 50 grams of a skin of a baboon and so on. But because we are lacking, that body and so on, that's why then you find that they are sometimes locked up and so on. In Eswatini, what we have the associations and so on of traditional health practitioners who are neither sued and cannot also sue anybody and so on, but at least they try to gather together and so on. And we are still lobbying for government to recognize them in the sense that we do need a legal body that will standardize traditional medicine, standardize traditional health practice and so on. And it's not only just the traditional health practitioners. We also have people like the massage therapist, we have homeotherapy, even the traditional Chinese medicine is rampant in our country, and we would like that to be at least standardized and be legalized, and this is what we are lobbying for. So lastly, I'm seriously lobbying for our institutes of higher learning to look into the curriculum and not have it just a course. I would like to see it and learn about indigenous knowledge system, including our traditional African traditional healing practices. Then they can align and so on, and even know the types of traditional healers that we have, because sometimes you find that I will take, for example, an issue of Gumede in 1990, where he talks about Abatagat and so on. Those are witches. Then I wouldn't really classify them as traditional health practitioners because they are witches. But we have to learn about them and even learn about how do people witch other people so that then you can counteract and so on. Just like we learn about our pathophysiology, and then we know what is it that we can do and so on. So all this information is very, very important. And even in terms of research, we have to do a lot of research in terms of qualitative and also ethno-grounded studies and so on, so that we gather as much information as we can, because the information that you have on the internet is being done by people who don't even understand what Africa is, what rituals are and so on. And they make their own conclusions. And that pass as a scientific knowledge that is now acceptable. But we do need to do ethnographical studies and so on, where we will really collect data from the roots, because it's not only just about traditional medicine. They also help us to keep our own customs and our own rituals and our own identity as an African person. For you being a Swazi, there are rituals that are done when you are born, and there are rituals that are done when you are dead and so on. Even in between, how you live your life and so on, to appease your ancestors and also to praise God, because God is there. Nobody has ever denied that. And that can even help our indigenous people, especially the Sangomas, who are now classified as witches, and that they will go to hell, so that they align and work for God, while they know that this aspect is just for healing purposes. And the religion has blocked a lot of traditional health practitioners from getting to heaven. We judge them and so on. Thank you. I will end here. with my talk, and I hope I've contributed to this revival of indigenous knowledge systems in the health profession and so on, especially the nurses. Thank you very much.
Thank you. Thank you, Dr. Priscilla Dlamini. This was really something that has baffled me. I really don't even have words to thank you. You have raised so many questions that I think our viewers must start asking questions. You have raised the issue that, and I think Dr. Mabena also raised it, that it doesn't mean that if you are a traditional healer, you don't believe in God. And I think that is very, very important. And that is a myth, that if you are a traditional healer, you are a witch, you are practicing witchcraft, instead of the healing that you are doing. We tend to understand when doctors wear stethoscope and when they use stethoscope to diagnose, but we don't understand when the traditional healers are using their, what are usually their bones, which for diagnosis. So I really think those are the things that we must look at. You also raised the issue of intellectual property. When they start working with allopathic medicine, they also have to protect their intellectual property. And then we have the protocol that is the Nayuga protocol that usually assists in this case. And I also liked the way you also roped in the issues of research. But most importantly, you also indicated that our allopathic medicine or our Western way of doing wants to dictate what is evidence and what is scientific evidence. And I think as we continue discussing, we'll also come back to this issue. But for now, I would like to introduce Prof. Vanessa Steenkamp, who is going to tell us about the value, the medicinal value that is in our indigenous vegetable. I eat indigenous vegetable. I eat mushiji, which is called blackjack. I eat voa, which is called amaranthus. And nowadays, when we try to introduce our kids to eat those indigenous vegetables, they feel those indigenous vegetables are also inferior. They would like to eat lettuce and also spinach, beetroot. They talk about cucumber. Today we are going to learn what are the medicinal values that are in our own indigenous vegetables. Prof. Steenkamp has conducted research in that. Over to you, Prof. Steenkamp.
Thank you very much, Professor Molodzi. Yes, I won't only just be talking about the medicinal value, but or the nutritional value, but the medicinal value as well of traditional vegetables. It will also be from an aspect more of a research perspective on how we found this out or determined the activity. So just a brief background, we know that 80% of our population uses traditional remedies in Africa. It forms part of the primary health care, as was alluded to earlier. And the medicinal use of medications has been going on for generations, absolute generations. But what we must also remember that for many people, this is also a food source. And it's a powerful source of nutrients, especially where there is a lot of poverty. What do we know about food and medicine? Well, both come from the world of plants, both are eaten, they both affect human health, and we very well know that an inadequate diet will result in poor health. So to protect you against inadequate diets, you should be taking a lot of vegetables. And if you see on the right-hand side what a balanced diet constitutes of, 40% of it is our vegetables. So it is a huge part. Now, food as medicine and medicine as food is not a new concept. It already dates back to Hippocrates. And also, I believe that the traditional healers can tell you that this is something they've been using for years and years and generations, as I've said, not just medicinally, but also as a food source. So, medicinal plants are still widely used today in chronic disease states for treatments. Although the graph on the top indicates the Western system and the alternative system as an imbalance, it should actually nearly be the other way around, or the even, because we should be looking at it as a holistic approach, as a complementary approach to each other. Although a lot of people do use medicinal plants due to their cultural beliefs, or because Western medicine is not effective and they are desperate for a medication. But in many cases, they do work. And as the previous speaker said, that they contain compounds that are active and have activity. So we have to be very careful when we work or use the two in conjunction. But they do also maintain and promote health. They have been shown to have cytoprotective activity, for instance. So what is that? That means it provides protection against harmful agents. If we have a look at on the graph or the figure on the right-hand side, we can see an example of how this happens in, for instance, just diabetes, where it protects the heart, the vessels, the kidney, and even the retina. For all the other illnesses that we can get supplementary to the primary disease. And also that will then eventually protect in cardiovascular events in the old end or even end-stage renal disease. So there are various protections that take place within the body. It can even be neuroprotection. We know of a lot of medicinal plants that are used for that function too. So I've mentioned that they also have, that they're cytoprotective, but they also have antioxidant activity. I am not going to go into that aspect at all because that in itself is a very long lecture. But all plants, all the medicinal plants do have antioxidant activity, which is very important in disease states. I am going to discuss together the antimicrobial activity as well as immune-enhancing activity, because this is extremely important, especially in the time that we are facing with COVID. So we are subjected to zillions of microbes, be it viruses or bacteria, and the magnitude of these viruses well exceeds the number of cells in our bodies. The problem is that not all of them are bad for us or harmful to us, but they can be potential pathogens. Now, the immune system has to mount a very rapid microbicidal response to invading pathogens. If this does not happen, it can lead to chronic inflammation, metabolic alterations, malignant transformation, and even immunosuppression. And if you look at that picture of the hand, this is just maybe to remind you, although we might not want to be reminded, of the amount of microbes in or around us, and that is why we are washing our hands so much at the moment. So what indigenous vegetables, or may I call it plants actually, because they're leafy material, have immune-enhancing activity and will keep these microbes at bay? The first plant is Bedin spilosa, or commonly known as the blackjack. The plants that are used are the leaves, the roots, the seeds, and these can be dried or they can be used fresh in sauces and in teas. The medicinal uses traditionally are to treat hives and for urinary tract infections. Scientifically, in vitro and in vivo, so in the laboratory or in animal studies, they have been shown to have antibacterial and anti-inflammatory activity. If we look at the nutritional value, it does give us a lot of energy, which is important, protein and carbohydrates, and then also beta-carotene. Then we have the sow thistle, where the leaves are used as a salad, soup, or even as a spinach, which has been shown to have, or is used traditionally, for antiseptic, for the treatment for cancer, for inflammatory swellings, and the activity has been proven in the laboratory for antibacterial, anti-inflammatory, and anti-diabetic activity. Most notably here is, except for the calories that it gives you, so the nutritional value once again, it does form part of a source of vitamin C. The wild spider flower, which gets its name from the way the flower looks with all the appendices on it, is the parts used there of the tender leaves, the young shoots, and the flowers. And these are used as a pot herb, or it's basically like a spinach, and for the treatment of rheumatism and pain. Has once again also been shown to have antibacterial and anti-inflammatory activity, very rich in vitamins, A and C, as well as a number of minerals, especially your calcium, your iron, and magnesium, that will be very important for people with, for instance, anemia. The wild cucumber. You can see the fruits there, and if one opens them up, they're full of pips. They look just like a normal cucumber does. They're just bigger, and it's a bit of spiky on the outer end. It's used as a purgative and jaundice. And yeah, the leaves and the fruits are boiled or stewed, and they even pickle them just like a cucumber, and they can use them fresh in salads, or then pickled in salads, or even in hamburgers, believe it. It has been shown to have antibacterial, anti-inflammatory, and anti-tumor activity. Once again, very rich source of vitamin C. So there we can see the effects that it would have. For instance, if you do have flu, flu. Also minerals for calcium and magnesium, good for bone growing as well. The stinging nettle. Another example of a plant with antifungal, antibacterial, anti-diabetic, and anti-inflammatory activity, very rich in vitamins. And then one very famous plant that is used as a tea in our country and not as a vegetable as such is the cancer bush, Sutherlandia frutescens. Medicinal uses have proven positive for treatment of cancer, HIV, and to be used as a general health tonic, and also for people with poor appetite, so that they do not have wasting. And this has been shown in preclinical and in some clinical trials, although they were very small. And I wonder if this does not have the potential also to be developed for maybe something to be using for the treatment of COVID, and something we can be having a look at. A proud South African product that is marketed but can also be investigated further. Then the black nightshade is the last plant I'd like to have a look at, where the leaves and the fruits or the berries are used. The leaves are cooked and eaten as a spinach, and the berries are eaten as is. The medicinal uses traditionally are for cancerous sores, for treatments of that, and as a purgative, so to wash out the body. And then also it has been shown to have antispasmodic and anti-inflammatory activity. A huge lot of vitamins are found in this plant, A, B, C, E, and folic acid, very important, especially for pregnant women, or women that want to fall pregnant, which I should rather say. And then also a high protein content in both the leaves and the fruits. The one thing about this plant is you have to know that it does contain a toxic compound, solanine. It's a glycoprotein, or glycoalkaloid. However, if the berries are eaten when ripe, there is no problem. And these are some of the characteristics that the traditional healers are aware of. When can these be taken and when can they not be taken? For somebody that doesn't have this knowledge, this is a problem and can be fatal. So I'd just like to conclude to say that although I've given you the only one example, and being also a toxicologist, we must not assume that plants are safe since they're natural. Western drugs and herbals have interactions. We very clearly heard that from the previous speaker. And also we must know that the behavior of many substances depends on the dosage. The dosage within a plant will also depend on the season as well as the region in which it is grown. But the most important takeaway from this presentation today is that indigenous plants constitute a great promise in efforts to promote health and to prevent chronic diseases, as well as being of nutritional value. Thank you.
Thank you, Prof. Vanessa Steenkamp. You really gave us food for thought. We really appreciate what we have learned from you today. I saw one of the indigenous vegetables there. We call it murudu ngachivenda, and I think in Sipedi kilirutu, and we really like that so much. So I'm saying to our viewers, please eat indigenous vegetables. They are very important. You have learned how they have nutritional value as well as how they have medicinal value. So it's very, very important that we be proud of what we have as Africans and things that can be packaged at the end and help us. I usually look at the way the Indians use the spices to treat themselves, and each and every spice that you eat has got medicinal value. I remember one day when I was not feeling well, I say I can't sleep, and a colleague said, no, just take milk, boil milk, put in 2 teaspoons of turmeric, and then you will feel fine. And I slept very well. So it is very important that we as Africans also be proud of what we are eating, because I believe that our ancestors, when they started saying this is morojo, is because they have done their research. It is not the scientific research that we know today, but it is another way of research that they have utilized to be able to say, this plant you can't eat, but this one you can eat as morojo or indigenous vegetables. Indeed, currently we are all talking about herbs. And I would now like to introduce my colleague, Dr. Mahoro. I met Dr. Mahoro as early as 2001, and he was telling me that, you know, you mustn't eat this, Western medicine. It has got a lot of side effects. You see, if you can just take lingana, wabona lingana will really help you a lot. And that was in 2001. We are now in 2020, we are hearing about lingana coming from Madagascar, when we had our own scholars and our own researchers here in South Africa, but we didn't listen to them. He even had a small booklet that had all these herbs that can be used for healing. Today, I present you Dr. Mahoro. The stage is yours. Tell us about herbal medicine.
Thank you, Prof. Now is the time. The time is now. I think Prof. Namatendane has introduced us in such a manner that, you know, whoever was saying something, for me, I'm so surprised because I was looking for something for a longer period, not really coming. So when I was, in the field of indigenous knowledge systems, I thought maybe one day the government will understand us and the government will give us the opportunity to explore in the area of traditional medicine, in the area of indigenous crops, even livestock. The generic term of farming, indigenous farming systems, because I'm in the line of agricultural science, so sometimes you feel like we are not doing enough. And as you see me, you can think maybe I'm 23 years old or 35 years old. It's because of the way I eat and it's because of the way I use these traditional medicines. So when coming to the point of decolonization, yes, we are still decolonized in such a manner that, let me come into the issue of two information systems. We do have what we call explicit know-how and implicit know-how, meaning we are having two ways of understanding and two ways of knowing. And the information from the explicit is when we talk about the Western ideologies that are generated in the academy, and also, you know, as Prof has already alluded, it's a planned activity. So if you are not moving away from that Western ideologies, I'm telling you are not going anywhere, because we are still going to say our medicine should be subjected to whatever tests and so forth. And when Prof was presenting on the indigenous crops, you know, the language is very important. You can't say Leroto and somebody say a different thing. We've written some documents pertaining to the indigenous vegetables, and I realized that there is a lot of distorted information, because somebody is talking about moroho, but in the book it's maroho. So the meaning is totally different. And you know, Prof, the Leroto that we have presented, that's Cleum ginentra. It's basically Leroto. And when they want to distort the info, they say it's cat whiskers. You know the cat whiskers? Malejwana akazana. So it's a different meaning altogether. And when you talk about that, then the info, you know, it disappears. So we are very proud about the way we reflect on our knowledge systems, and we must be very proud about the way we present things, the way the grannies were presenting that. So we've got scholars, basically, in indigenous scholars. If we were to develop any form of curricula, we must really look into the issue of indigenous scholars like Fanon, like Chiliza in Botswana, is just nearby, many in the Cabo. So there are many studies that has been conducted pertaining to indigenous, but it should be studying from the indigenous way of understanding, even indigenous research methodologies. Because if you don't really put the indigenous research methodologies, what method are you going to utilize when you conduct the research? In my presentation, I'm dealing with the decolonizing communities, you know, pertaining to the use of medicinal plants and the preservation. The point I want to raise here is, when you talk about communities, I'm not referring to rural or urban, because we must define what is community. The definition is all, you know, deals with group of people. But there is these groupings, you know, the groupings whereby you find there are academic people, you know, the researchers conducting research based on the Western ideologies. How can they really assist our communities? They won't be in a better position to assist our communities, because basically they will be dealing, you know, conducting research for their own benefit. So language also is very critical in whatever we are doing. I saw, you know, I've been to different countries trying to find out whether Leroto, are they really growing Leroto, or the naming is coming from somebody. You look into the area whereby, because when I'm talking about explicit knowledge or know-how, the information is quoted, is in the book, while the tacit or implicit knowledge or know-how, the information is in what? In the brain, in the memory. So when you read, and when somebody is trying to inform you about a particular event of 1956, I mean, Med Lamin was talking about Witchcraft Act of 1909. And in our country, we are talking about Witchcraft Act of 1975. We don't know whether it's still existing or what. But the fact of the matter is, you are talking about the healing, you are talking about the way you administer medicines. I'm talking about the way I propagate. the medicines. I've been propagating the medicine for many years, but the unfortunate thing is, if people are not decolonized, how are they going to utilize that medicine? If people are not decolonized, how are they going to preserve those medicine or those indigenous vegetables? As I'm speaking now, there is this tree, shepherd's tree. We call it mupipi. Mupipi. It's a very crucial and very important tree that is linked to the rainfall. But if somebody doesn't really believe in that, the person will definitely chop the tree. That's why next to the road you'll find the marula tree not being removed. It's because it's of significant importance in our life. So they can't remove marula because they know it's very important to us. They can't allow that. But because somebody doesn't really believe in that, it's colonized, then the person will remove the marula. So when it comes to indigenous vegetables, we must really work harder, and I'm still eating what you call the tots, melon seeds, indigenous melon seeds. You fry them and you become yourself. They've got that nutritional value. And we must really encourage people to grow that because they are drought tolerant. When you talk about drought tolerant, it means that the marula, the melon, when it's planted, under any harsh conditions, they can perform very well. You can feed the livestock, you can even eat that, the seeds. And when it comes to the point of, traditional medicine, basically I wanted to support Baba Mabena, Dr. Mabena, on the part of people taking, they don't feel like our medicine whether when we administer the medicine they are working or they are not working. The big debate about Artemesia Afra, that's Lengana, you can Google, you go to Google and say Artemesia Afra. Research has been conducted for many years. But the debate is who's going to tell us when to use Lengana. Are we waiting for the Westerns to tell us to use an African medicine? Are we waiting for any word from somebody? Because this has been used. You can cook that, you can smoke. Like the daha now, you smoke and you even drink. So this has been there for some years. And I think it's now time, as Prof. Mlaudzi is indicating, it's now time that we work on this, we propagate this. We've got projects anyway. They are dwelling much on the issue of indigenous teas and the road to packaging and so forth. And we don't really need somebody from somewhere to teach us on how to cook our stuff. There are indigenous recipes, and we are going to embark on the issue of developing indigenous recipe book pertaining to, the indigenous recipe book will be looking into the issue of how to cook, khodu. Unfortunately, I don't know in the foreign language what that's khodu, but you use an indigenous melon. Then if in a particular household they don't have enough, they can cook that and it will be enough for that day or two and so forth. So we are going to encourage that, and we must encourage the production of indigenous vegetables and medicine. So it's easy to propagate Artemesia Afra. I was wondering why people are struggling to get Artemesia Afra. I'm able to propagate traditional medicine, Artemesia Afra, and even Leroto. You can plant Leroto on a hectare using seedlings, for your information. So it's easy to propagate from seeds. So it's time that we start working on this one. Because Leroto is a pot herb. It's a shabo foreigner, it's a shabo, and on the other hand, it's a herb. You can even utilize that to cleanse your eyes and whatever. So it's a herb on the other hand, but on the other hand, it's a medicine. So we must start doing that. But when somebody is talking about documentation, because, you know, in some areas they say you don't document. The failure of an indigenous researchers is that they don't document. We document here, but on the other hand, we are able to code them, put them into a proper document. It's unfortunate that whoever is taking traditional health practitioners as people who are not really learned, here we are. Yeah, we you know, there's no way we can say because you are not learned, then you don't know anything. Which knowledge is better than the other? Which one is better than the other knowledge? Because Western and Indigenous, you know, you can't really say the other knowledge is better than the other one. So what I can indicate to you, Prof. Mlaudzi and our colleagues, is that we really need a relational epistemology, axiology, and entomology, ontology that we can really put forward in whatever we are doing. Otherwise, we will be failures. I think whatever we have started, we must really make sure that we implement. Remember, we've got an indigenous knowledge systems policy in the country. And how they are implementing the policy really is not up to our satisfaction. It's not really enough. You can't have a policy, an indigenous knowledge systems policy, and add Western ideologies in the document. You really can't really do anything. But, you know, we need to complement with each other. Yeah, the knowledge system should basically complement each other. I think you have said a mouthful. That's why I don't have ways to really put my presentation based on my way of doing that presentation, but you've already done a lot for me. Yeah. Thank you, Prof.
Thank you so much, Dr. Mahoro, and I really think you have highlighted issues that are really very critical, that if we really want to see indigenous knowledge getting space in our curriculum, we have to also look at doing research differently. We have to look at our epistemologies, our axiological and ontological way of doing things. So I really think now it is the time to introduce our curriculum expert, Mweta Mavicha, who is currently the PhD candidate. I think you have learned a lot out of what has been discussed here. And now your role is to look at, indeed, we are coming from, we have been taught, I'm also taught from a Western way of doing things. And when you tell me, Uri, now put this into a curriculum, then I will ask, Uri, what do I put in the curriculum? Because Dr. Mahoro is saying it is in the head. How do I take what is in the head and put in the curriculum? What exactly do I need to really, conceptualize indigenous knowledge system and make sure that it is taught in our curriculum? We have already started, but I heard Dr. Priscilla saying you don't need a module. You need more than a module to be able to, propagate the knowledge or to promote the knowledge. And we currently are having Dr. Mabena and other colleagues that are doing complementary medicine, like Chinese medicine. We call them once per year to just teach our nurses. But is that enough? And how do we ensure that it's not only nurses that are taught, the dental students, the pharmacist students, also our a physiotherapist, our occupational therapist, all of them have to learn as to how do we incorporate indigenous knowledge in our curriculum. Over to you, Mabija Mwe.
Thank you very much, Prof. And I must say I'm really honored to be part of this panel, and I'm really learning a lot as well from my colleagues from different perspectives. It's really an eye-opener for me as well. I think, Prof, as a point of departure, we need to understand, as Prof. Nemutandani said, the impact that colonization has had, not only on our lives, but on the way we actually teach and learn within universities. And I'm also waiting for the day where we will have, a true African university that actually embraces what Africa is about, and that, recognizes African knowledge for what it is and not distort it. And I think from where I'm standing, it is a bit disappointing that, the plea had to come from students to actually say, why are you not decolonizing the curriculum? And the students are actually the intended recipient of that particular knowledge. So it can be quite disappointing to say, where are we as academics? Why did the plea have to come from, the recipient? Whereas we as the planners should have been able to detect that something is not right, and that our curriculum is probably not responding to the current needs of our country. And I think it's across the board. It's not only in health sciences. I mean, you can go to engineering, you can go to even other professions. It's still a problem. And I think we are finding ourselves in a very difficult situation because, the problem is not only systematic, but it's also very structural by its very nature. So there's quite a lot of resistance, and that resistance is not from just, the individual perspectives, but the system has been set up in such a way that you're going to have to prove yourself. And I think that is the point that you were raising, that then how are you going to really validate, the IKS using Western methodologies? And I think it's a conversation that we need to also start having, that which method are you using to validate the information that I'm putting on the table? And I think myself, coming from a nursing background and doing nursing education, we have had a lot of problems with our nurses. You know that there's widespread news about nurses having bad attitudes and patients not being happy with how they are treated. I mean, there's research and a lot of literature available that reports that patients have actually been scolded or turned away upon showing signs of having consulted with traditional healers. Nurses are intolerant, and it's not only nurses, but doctors as well. And I look back, at my curriculum as a curriculum person who has drafted this product to say, am I doing the right things? What are the things that I need to put in the curriculum to make sure that my nurses or my doctors or whatever the profession is are actually tolerant of the other system of healthcare? And I think we also need to start looking at the coexistence of the two. Can they coexist, or who must adopt who? Because that is where the actual debate is as well. That IKS practitioners are saying, but we are a valid system ourselves. And if you want to come to us and take our knowledge and put it in your curriculum without consulting us, then you're going to have serious problems with that. So as part of what we do in nursing, I think we need to start looking at what is the content that we're currently teaching that is actually preparing our nurses to be, nurses, doctors generally, to be better practitioners, to respond to the local needs. Because it doesn't help to say we are teaching our nurses about cultural diversity and issues of culture included, but they are not necessarily relevant and responsive to the African context within which we find ourselves. I've seen in the nursing curriculum, we actually teach nurses about Leinenga's cultural diversity and universality theory, which actually talks about different needs of a person, cultural needs of a person, and how that can be met. But its contextualization becomes very problematic, because you are telling a nurse about a theory that had been developed elsewhere, and it does not necessarily consider the local context and the local factors that would influence how that person interprets the theory. At the end of the day, you will have people who have been to class, who have been taught things, but they can't really put them into practice. They're still very rude. And the Ubuntu model, I'm happy that we're actually talking about Ubuntu now, because I think that is what we really need to start teaching in our curriculum. because you can't be teaching people to take care of people, but you are not actually getting them to care for people. You are teaching them to care, but they don't care. They leave your programs and they are still, maybe even worse than how they came in. And maybe there's something in the system that we're not doing correctly. So I think, Prof, as a point of departure, the first thing that we'll need to do is have, structural reformations at institutional level, but also at a personal level. I think people need to start reflecting about their own prejudices, and be open to learn from others. And I think that has been, the theme of the day, to say we need to understand that we can learn a lot from each other. And we need to start respecting, other people's, knowledge and point of view. The curriculums that we have in the institutions, whom do they represent? Usually a curriculum is a team effort, and we will sit down as a team and, come up with learning outcomes and goals and where we want to see our students. But should there be somebody there who does not believe in what we're saying, that might actually distort the whole, meaning of what we're trying to write down there. An example would be if you were to tell, a group of academics right now, sit down and say, let's have a module and call Dr. Mabena in to come and teach the module. The first thing they will ask you is, what degree does he have? And I think that is something that we need to start talking about, to say sometimes the sources of information might not necessarily be, from the background that you are from. So we need to start having that kind of conversation. And I can assure you that most curricula in the institutions actually represents a certain individual within that particular institution and what that person stands for. If that person does not believe in traditional medicine or IKS generally, you will not see a single thing in the curriculum. But it is not limited to that. We need to also start talking about issues of regulation, because obviously if you are to teach things, your professional councils must actually also give you some form of leeway or some form of permission to do such. And therefore, we need to engage on what can the role of the councils be in actually facilitating the process as well, because they can be the gatekeepers and they are the ones who are going to give your curriculum a thumbs up. I think you need to engage them from the beginning as well. But most importantly, for us to convince them, I think we need some form of competency framework, some form of standard that says, this is what we want to see our practitioners doing in terms of traditional medicine or IKS. And I think within that competency framework, that's where you're going to, see issues of the skills that are required, the knowledge, and the attitudinal issues that you want to prepare these people, actually, for them to deal with the challenges. And I think we have been trying at the University of Pretoria. It has not been easy, but I think we have been seeing quite a lot of positive responses from our students. When we take our students to the field, to the actual practices where Dr. Mabena would be practicing, our students, they come out as different people. And we do know that there are nurses and doctors and other health practitioners who are willing to work with traditional practitioners. So what seems to be the problem and what seems to be, that stumbling block that really is preventing us from moving forward? And I think these are many things that we have to start engaging. I thank you, Prof. I think we can.
Thank you so much, Mr. Mieta. I really think you have added so much into the discussion, more especially when you talk about the regulatory body. What is their role? Because they are the ones that usually determines what we are supposed to teach. And if the change in mindset doesn't start there, they will start asking us, well, what exactly are you teaching? Why do you have this kind of module? And also the qualifications that they require for a person to teach. And I think those are the things that are really very important. The competencies. They are the ones that gives us the competencies, and we have to teach based on those competencies. And I think that is really very critical. Ourselves, change of mindset. It really needs a critical thinker to be able to understand really for the past 35 or 40 years that I have been thinking that I'm an educated person. I am educated, but I don't know what I can call it. I'm educated from the one side, but the other side I have really not looked into. And then when people start talking about it, it's then that my eyes are opening, and I ask myself, I have never had an opportunity to really learn from this kind of knowledge system. I really liked it when you talk about implicit and explicit knowledge and how important it is and how do we change this, for example, moving from tacit knowledge and making sure that this is the knowledge that now Mabija can put into competencies. I think those are the things that are really very important. We have got a few questions that we need to address. There are 3 questions. I'll first ask the one that I will pose to Prof. Mtandani, and it is about where do we place faith-based healing in all this discussion that we are having today.
Well, it's a challenge that we need to think a little bit deeper. The faith-based healing, if we could go back to it in terms of the Traditional Health Act in South Africa, it's still a debate as to whether it should be part of traditional healers and whether it should stand alone as an item, not with the traditional healers. And I think within the Traditional Health Act, it has been incorporated, but traditional healers themselves are saying, no, these people surely do not belong to us. And I don't think it would be easy to answer it now, because there are certain things that are important here to realize. One is that they are using spiritual, religious type of healing, whereas indigenous, they are using a different mechanism of healing. That other one is based on the faith or believing in using the religious aspect of it. The traditional one is not using the same. But let's put it at the bottom of it. Who provide healing? Western doctors or Western trained practitioners do not heal. Even traditional do not heal. It's the creator, as Vanessa has shown, is the creator. And who is the creator? The body itself has the capability of eliminating the virus, the bacteria, whatever. When it fails, you then introduce an item from outside. Whether it's antibiotic, whether you use the herbs, it's an augmented treatment. You are augmenting what the body has failed. But for them, they believe in the spiritual world, not using the herbs or whatever. And I think maybe my traditional healer, Dr. Mabena, could add more in terms of what has been the debate.
I should think you have said it mouthful.
Okay, thank you, Dr. Mabena. The next question comes to you. It's about how does one differentiate between bogus traditional healer and professional traditional healer? Please explain the PHC approach in traditional healing. I think let's first do the first one. How do we differentiate between the bogus traditional healer and a professional traditional healer?
Let me start by saying that's where now, traditional healers and the government, we're talking about the, THP Act. When you talk about the bogus traditional healer, you're talking about smart people who can outsmart smart people. I myself, it's a question, and that the lies in the mindset of a person, they goes very, very well. And that is actually has resulted even today that people always believe liars than, I'm trying to say to this, why they are so smart to such an extent, they are advanced in lying, in conning people. So it's actually giving the traditional healer industry, very difficulty for the community to identify the bogus traditional healer and and the true traditional healer, because they can fake very well. And that's where collectively as traditional healers, we need to stiffen, you know, the act itself, not the act to be drawn by people who are not actually believe in our system. We have to actually to put guards collectively as traditional healers, so that is why to say we come, the act stipulate quite a number of few things. Surely in order you to become a traditional healer, give us exactly your qualification. Who made you a traditional healer? Did you wake up early in the morning and decide to become a traditional healer? And who are the witnesses? Who can, it's like a person who graduates. Surely there must be witnesses. And it goes hand in glove and say, who was there? Who graduated you? Who was there? The community must be part and parcel of, you know, to witness that exactly. And show the scars. There is a history to tell in order to become a traditional healer. You don't just exactly wake up and say, okay, I'm going to wear up this nice regalia. This is not for fashion parade. This regalia, this kanga is not for fun. It's part and parcel of this prescription that was prescribed by me, by, you know, my ancestor, including my Kobela, and to wear this even if you wear your graduation regalia. Surely you don't just go to a tailor who can just sew it for you and you wake up having that nice suit and say you're having a graduate. That's where now we fit in and say collectively, the traditional healers and the government, how can we help each other to make sure that we weed out these bogus traditional healers?
Okay. Thank you, Dr. Mahoro. I think you want to add?
Yeah, I just want to add on what Dr. Mabena has already indicated. You know, the purpose of Traditional Health Practitioners Act was to regulate, to be in a better position to know who is the real traditional healer, you know, to remove those professors. You know, there are adverts around in town about Professor A and Professor B. So it's to regulate, and when people who are real traditional healers, they will be in a better position to register. And once they are registered, somebody will witness and say, yes, this person has been a traditional healer for the past 10 years. So you can't wake up tomorrow and become a traditional healer. And this is increasing. There is a trend of those bogus, as Doctor has already indicated. That's the bogus, you know, the trend is it's there. Because the government is also delaying the implementation of the Traditional Health Practitioners Act. That is, you know, there are form of delays. And the act has been there for some time now. If they can implement that, I don't think the doctor will be talking about the bogus. Because that's the purpose is to regulate. Yeah.
Thank you. And then another question is for you, Dr. Mabena, again. I would like you to clarify the referral system from the African traditional practice. Is it from traditional to traditional or traditional to Western? The referral system, how does it work?
No, thanks, Prof. I should think, as I've alluded, as I've said in my presentation, that Prof have said a lot, colonialism. We are actually, you know, so colonized to such an extent, I can't even explain. This referral system is cocaine, stroke, if I can say. And it's cocaine because of knowing very well that it's actually from traditional healers to Western doctors. It's not supposed to go, it needs to be balance. But most of the people who come to traditional healers, they will always, they don't come because a traditional healer has failed to cure, but has come because there is a blockage that has been done by the employers, that you need a letter. They will not take a letter from me as a traditional healer. My employer might not take a letter, you know, to say you are from the vertical. That's one obstacle. That employment industry refused to take a referral letter from a traditional healer. That's where now, actually, who suffers at the end of the day? The patient. And those are some of the things. And I will make that as an example that there is no referral from Western doctor to a traditional healer. I've never seen that unless that particular doctor is in good, working relationship with a specific traditional healer, but it's one-sided. Yes. Emanates from that distorted information, distorted belief system of saying most of the doctors, as I've alluded, that most of the doctors are Christian-orientated, doctors and they are nurses. So therefore, the letter that comes from a witch doctor under Witchcraft Act, they will not take it.
Thank you, Dr. Mabena. I really want to say, when I started becoming interested in indigenous healing, I was very lucky because in the hospital that I was trained, we had doctors that were coming from Netherlands. And they would be the ones that would refer patients to the traditional healers. And there was a very good working relationship, and the traditional healer will refer. So I saw the system working. I was at Siloam Hospital when I was training as a young nurse, and I saw that happen. So I became interested. They were treating the disease Goni or Rigoni, and then the lady doctor would say, no, to the women, I think your child is not responding to treatment. Go and get a traditional healing, and they would say, leave your baby here and go and get treated and come back. And then when I started, when I continued studying, when I heard about IKS, then I said, no, let me go back and look at what exactly was going on. Why were these people being referred there? And how did they benefit out of it and so on? And I think it is very important that as allopathic health practitioners and also traditional health practitioners start looking at how can we work together. So I think now I will also ask another question here. One of the panelists may take it. It says, please explain the PHC approach in traditional healing. The primary health care approach. Who is going to take that one?
Maybe we should start by saying most of our community, when they want to consult, they go to traditional healers. The first entry, research has indicated that traditional healers are consulted immediately when there is a condition that they feel they need somebody to help them with. That is the primary healthcare approach first. Before you even get into secondary and tertiary services, primary healthcare entry point is the traditional healers. Now, we need to understand how the health system has been structured. And I think Dr. Mabena explained that the medical certificate, the hospitalization of patient and the structure and the funding system decided to take everything from the primary healthcare approach. And I'm thinking now as we are debating that national health insurance and national health coverage is coming, universal health care, it's coming. Most of our patients, they would need traditional healers. Is the plan thinking incorporating our traditional healers? Probably no. They are excluded, and this is the challenge to the policy makers and also to our government, that most of our patients would seek treatment from traditional healers, and they would not be probably compensated or even recognized. But we need to advocate for indigenous knowledge system and the healthcare system that has been working for years. And for me, that question, I understand it to say, is there a role for traditional healers in the primary healthcare approach? And the answer is yes. Research has shown that. But we need to go back to say what has happened. And I think I need to agree to what my colleague and my learned academic has mentioned. The problem is that colonization has created poverty of mind among our people. And slavery. You know, the slavery of mind, it's more dangerous than the physical chains that has chained most of us. We were chained, we can see the chain physically, but the one that is in the mind, it's very difficult. You may have professors, academics, those who've got PhDs, but in the mind they are still enslaved by colonization. And it's very difficult to break these shackles because you cannot see it. Most of our institutions got black vice-chancellors, head of department that are black, Africans, but Nicodemously. They go and consult Boma Bena at night. Nicodemously, they go there and say, Boma Bena, I could not get treatment from Western doctors in Tusemo. During the day, we would be wearing the white coat, ties, and PhD gowns and say Western medicine, it's working. And that has been the challenge. Now here we are, we've got universities, we're academics. Most of the PhD work that has been produced, it's advocating that we need to change. But change is not coming. Our research are gathering dust somewhere in the libraries where wonderful work has been done. You have written books and whatever. What is the problem? It's the poverty of mind. Trying to move from the concept of we can do it ourselves. We submit ourselves, even the research, the knowledge. I try to argue that our research committees, once you want to do something that they do not understand, they say that's rubbish. How do you get ethical approval from ancestors? How do you consult Boma Bena and ancestors say ethically you can go ahead? They say it's rubbish. Now that is where the problem is. And I'm challenging our universities, the HODs, the deans, the vice-chancellors across the spectrum of our university to start to take indigenous knowledge system seriously. Otherwise, we are just giving a lip service to say we have transformed. We have not. Thank you.
Thank you very much. We only have a few minutes left, and I can just give each and every one of you a quarter of a second to just say your last word. I'll start with you, Mr. Mweta.
Thank you very much, Prof. I think indeed we all acknowledge that there's a lot of work that still needs to be done, but we also have to, give credit where it's due, where good work is being done by some of our health professionals who are really pushing, for inclusion of IKS in the curriculum. I would think, I agree with Dr. Dlamini that, it would need more of a course than actually a module, because there's so much to learn. I think all our different disciplines are actually included within IKS. So you would need more than just one module. I am saying we are open to work with traditional health practitioners. We want to learn from them so that we can assist our nurses, our doctors, so that they can learn also, this is who we are. And, you can't divorce yourself from your cultural, language and, demographic basics that made you who you are. So I think on that, Prof, I think we have a long way to go, but we can work hard to get there.
Thank you.
Yeah, what I can say is that cultural connectivity should prevail. We must engage, we must be sensitive about what you do, and at the end of the day, we must get approval.
Thank you. Prof. Steenkamp.
Thank you very much. I think there's much more integration required. even between disciplines, between the medical discipline and even the nurses, occupational therapists, so our healthcare sciences or allied sciences as well. Definitely revision of the curriculum. And this is not just a thing based at one university. This is a country-based revision that will have to take place. It is very ironic that traditional remedies are recognized as primary health care, but we're not teaching it. So there is a lot of work to be done there. It's definitely not something that's going to be done in one module. It's got to be restructured, thought of in various aspects, and really be brought in. And definitely with the buy-in of the Health Professional Council as well. So that is the one way to start with this. Thank you very much.
No science is the jack of all trades. No science is bigger than any science. We are scientists in our own right, in our own space. It needs to be very clear. If we don't work collectively, we will face the situation like Boesi. This country will face lot of disasters. Each one teach one is very, very important. Let them come and learn from indigenous knowledge holders about Ubuntu and the disaster we are facing, like Esitimene and other problems that the country is facing, especially on health issues, I think can be solved. I thank you.
Decolonization should be a planned project with champions and well-funded across all universities. Otherwise, it will be just a lip service. Thank you.
Thank you, my panelists. It was really a good afternoon. We have learned a lot from each other. And I just want to say, as we continue holding hands, promoting IKS, let's have a goal and ensure that IKS is mainstreamed in the curriculum. The time is now. We are not going back. Let's proceed. United we stay, divided we fall. And I am so excited that traditional health practitioners talked about the issue of One Health a long time ago. They talked about the fact that you cannot be talking about health without looking at plants, without looking at animals, without looking at water, without looking at environment. Today we are seeing a global move to embrace One Health, and the leaders of that were indigenous health practitioners, although they are not going to get credit. With that, I just want to say to the viewers, thank you so much. We learned a lot today. IKS is here and is here to stay. The time is now. Let's change our curricula. Thank you.
At the University of Pretoria's Faculty of Health Sciences, we like to focus on potential. The potential of our students to make a positive difference to the world around them. The potential to produce research that shifts boundaries. The potential to heal, to relieve, to recover and restore. Discover your potential and join the movement. Follow the University of Pretoria's Faculty of Health Sciences on Twitter, Instagram, Facebook, YouTube and LinkedIn to be a life changer.